the average for survival. So we're right around that 40 to 50% survival. Last year we did right around 100 cases of ECMO. This year we're a little bit under that, but it's close. Be close to that for the year. Alright, so we'll talk a little bit about apheresis, and then if you guys have any other questions or anything that you guys want to talk about. So when we're doing plasmapheresis, we, as a nurse and an ECMO specialist, I have to have a perfusionist present during the plasma exchange. Simply because it involves sometimes cutting into the circuit, and it's just a riskier procedure for the patient. So we have a perfusionist that supports our team, and they have to be up there during the procedure. So the first thing that we do is determine our volume replacement. So we need the patient's plasma volume, and we figure out whether we're going to use albumin or FFP for our plasma exchange. So to figure out the plasma volume, we need the patient volume and then the hematocrit. As an ECMO specialist, we don't determine whether we use FFP or albumin. That comes from usually the physicians, the apheresis team, the physician, and then our physician that's running ECMO. They usually determine that. The indications that I've seen in my time as an ECMO specialist has been mostly for acute rejection or pre and post heart transplant. I don't know, have you guys have we used it for anything else related to ECMO? I couldn't come up with anything else.
We're plugging.
Good pastors as well. So people who have pulmonary failure, when we do that for good pastor disease, I've seen it used, not here, in a couple of instances where we're using it for pulmonary failure.
Yeah, and I know there's places that use it for sepsis and I mean all kinds of other things, but directly related to ECMO, I was like, well, I think the only thing I could think of was heart transplant.
Sometimes I know we've been called in because your circuits are like have fibrogen in it or something, and we need to pull off some of that tissue or clear those columns in your circuits.
Yeah. Okay. So a lot of times it's either pre or post heart transplant or an acute rejection scenario. Acute rejection, it's usually a 5 to 7 day course, I think, daily. Pre-heart transplant, which is what we did with Mario, I think it was 5 days that we did with him, and just to try to clear some of his antibodies and drop his PRA levels, so he was potentially more eligible for transplant. So FFP replacement versus albumin, basically the basic argument that we have against FFP is in our pre-transplant patients, they're getting a huge donor exposure. So I know that's often the risk of doing FFP replacement on those patients. But then there's some that don't tolerate the albumin replacement either. So pre-labs that we usually get are an ACT, magnesium, and an ISTAT blood gas. We use the calcium level off of the ISTAT. ACT is activated clotting time, so it tells us what our anticoagulation levels look like. So for anticoagulation on these patients, we use a couple of different things. In the past it's been heparin, and that's all we've used, and nationwide that was like the gold standard of ECMO. That's kind of gone out the window in the last probably 6 months. The world is moving towards direct thrombin inhibitors, so argatroban or bivalirudin. So that is pretty much all we use now. Regardless of that though, the plasmapheresis removes all of the anticoagulation from the patient. So we stop it prior to apheresis, and then we have to bolus prior to the replacement volume, albumin or the FFP. So obviously a very risky time for these patients because we're concerned about them clotting.
So you switched to heparin then?
No, not that I know of. We didn't switch to heparin on Mario, I don't think. I think we just stopped he was on bivalirudin.
Why are you moving from heparin, do you think?
Heparin it's just a hard drug to manage. It's different on every patient. It varies based on, you know, it varies based on everything, all their clotting factors, and it works differently in every single patient. Whereas the direct thrombin inhibitors are a little bit more stable, I guess you could call it. We just have seen our circuits look a lot better. We have less fibrin in them, we have less clots, we have less interventions as far as like cutting out clots, and it's been a really, really, really good change for us. So, I think it was Mario's circuit. He was on bivalirudin almost the whole time he was on ECMO, and he had very few circuit interventions, and his circuit just, it stayed clean. We didn't have any issues with it.
So we're going to probably have to address this a little differently, because usually you were always heparinized.
Yeah.
And we didn't use any anticoagulant at all. We just ran some saline through the pump.
Yep.
Now we have two choices. Otherwise, we can use ACDA, straight ACDA, which really slows things down. Otherwise, we use routinely a combination of heparin and ACDA.
You use heparin in your circuit? Yes. Okay.
Yeah, but we don't heparinize. We just, our solution is heparinized.
Yep.
And so we use about half of each, because we use a 26-to-1 ratio.
Okay.
Rather than a 13-to-1, which would be normal.
Sure.
So I don't know how that's going to affect yours, if you want us to use the heparin or the ACDA.
Yeah, I don't know. I guess I wasn't there with Mario's, and so I'm not sure exactly what they ended up doing.
We used normal saline for Mario.
Okay.
So he must have been heparinized.
Well, I think
They were using
Nope,
that.
he was on straight bival. I don't think he was ever on heparin.
heparinization according to whatever you guys do.
So that's the same as the effect as heparin. So if they're on that, we don't need an anticoagulant then?
Probably not.
It has about the same effect as heparin does.
It just works differently.
Yeah, you guys take care of all of that for
Yep.
us, and the last time I did ECMO, you remember, Matt? We just used straight saline. Yep.
And you guys didn't have any problems with clotting or
None.
anything like that?
No.
Yeah.
Yeah. I mean, it depends on the patient, but I know Mario's APTTs were like in the 90s to 115. Now, argatroban or bivalirudin, it kind of artificially bumps them a little bit. I shouldn't say artificial, but it bumps them a little bit higher. And then their INRs typically are in like the 2 to 3 range, depending on the patient. So those bump those up a little bit higher compared to heparin, but they also have a very more even effect on them versus heparin. We see a lot of ups and downs on their values.
And you don't have any problem not being able to reverse either of those?
That's always the concern. That was like the big resistance to going to direct thrombin inhibitors. We knew that they worked, and a lot of times we would run dual. We'd run heparin and then just run a little bit of argatroban or a little bit of bivalirudin, because we knew that it kept our circuits a lot cleaner. So the reversal is the big thing. There is no reversal for argatroban or bivalirudin. So our surgeons were like, no, you can't do that. But with that being said, they also have a very short half-life. So it just depends. Argatroban is cleared through the liver and bival is cleared through the kidneys. So if they have liver or kidney failure, it's obviously going to take them longer to clear it. But there is no reversal. It's just time, half-life. So that's the biggest.
Is it a shorter half-life than heparin?
They're about the same.
Similar?
Yeah. But again, it depends on kidney function and liver function as well, whether they're clearing.
So if you stop the anticoagulant prior to us starting our procedure, we're relying on that half-life then to keep things anticoagulated?
You need to know what that is.
Well, but we don't typically don't do that until you start. And I know there's been times that we've left the anticoagulant running as well. So it's been patient, and I've seen it all kinds of different ways. So, but typically we do have to do a bolus prior to your volume replacement.
You don't remove any of it?
Yeah, I think we'll have to discuss it.
Yeah. Yeah, and I don't know, because this is a newer thing for us too, I don't know that we've really had.
We don't do many of these, and then it seems when we do, things have changed.
Yeah. Yep.
And
Yep, and this argatroban bivalirudin thing going straight to that for anticoagulation is new within the last 6 months, because we used to run both of them so we could, they still were on heparin, but now a lot of them are not on any heparin at all.
Taking any of that out when we're doing plasmapheresis.
You're going to take some, but you're systemically anticoagulated, so it's not gonna matter much.
well, it will as you do the procedure.
Yeah,
Remember,
you
to
take
it
off.
the whole
But-
Yeah.
But
Yeah, because it takes it
that's
all off.
okay. I think
So
we
how
have
do
to
you
talk to
manage-
Dr.
yeah,
Yeah, we're gonna
how
have
do
to
you
talk to
manage
Dr.
that?
Winters about it. It's good to know.
Yeah.
Yeah.
It'd be good information for
Yeah,
us.
it's really good to know.
So it really shouldn't have any effect on the way that you guys do things. I mean, other than the fact that if we, well, I guess it
If you're not
probably will.
anticoagulated, if you're
Yeah.
not anticoagulating, then and
Your
we're
blood
using
circuit.
saline, we're not using any
Yeah, it's gonna make a
anticoagulation.
difference.
Yeah.
I don't know
Potentially.
if it's gonna matter or not, but I think we still need to talk about, bring
Yeah.
it to our physicians' awareness and,
Mhm. Yep.
and it might be irrelevant.
Yeah, I don't know.
I think they were running those, thrombin inhibitors all the while we were doing.
Through that, and that's
Yeah.
kind of what I thought. And I know with heparin, a lot of
I don't
times we
think-
used to stop it, and then, but that makes
I
sense.
think
But
they were running it all the while we were running.
Yep.
Because they said, don't worry about any anticoagulation, we take care of it.
And so
Yeah.
therefore you just use the saline.
Yep.
Yeah,
Yeah.
just hook up
And
and go.
maybe heparin was stopped before because you were adding heparin anyway in the
Right.
course of the procedure, which is why they completely stopped.
I mean, it's simpler if that's the case.
No,
Mhm.
because they said they would take care of all of the anticoagulation, don't worry about that, straight, they wanted straight NSA, and then the albumin,
mhm.
and no FFP.
Yep. And that was because he was pre-transplant.
That's
Yep.
something. That'll just a good game.
Yeah, so more to come on that, but definitely a big change for us. All right, so we'll talk a little bit about circuit configurations. Now, I don't know your circuit, so tell me if there's something that you want to know more about as far from my end. So we have to determine where our plasmapheresis connections are going to be. It depends on the patient and whether it's a pediatric patient or an adult patient, what our circuit pressures run. But we have a negative line and a positive line. So we have to figure out where we're going to connect to. Now, do your circuits you need a negative access and a positive return? Is that correct? You have to have a positive.
We need the
Positive.
positive on the draw side.
On the,
draw side.
On the draw side, you need a positive?
Yeah, because we're negatively drawing it off
Okay.
and positively giving it back.
Okay. So it's the same in the ECMO circuit, because we have a negative draw and a positive return as well. So there's several different places that I've seen that we've used. So here's your adult ECMO circuit. We have a negative draw to the pump, positive in between the pump and the oxygenator, and then a positive return to the patient. We, in my experience, have always connected to the venous side of the circuit, which is a negative pressure for us. So I don't know how that affects your.
Well, as long as you have pressure for us to pull out of.
Yeah.
I mean, we've always given, you guys have hooked us up.
Yep. Yep. And typically it's